So, hello guys, good morning. So, hope you guys are fine. And myself, Dr. Ajay Moria. After a long time, I'm going to continue our two short topic discussions. It's going to be part 9. Okay. So, actually, guys, this is the new and updated version. Okay. Updated version. I already added some points from the July exam. Okay. So, these are the reviews of my updated short topics PDF. So these are my students. They are very active in my group also. So okay. So guys, for the PDF, already the link in the description. Okay, this is the Telegram link, or you can message me in WhatsApp. This is the my Instagram ID. Okay, so these are the reviews. I came and I got so surprised. I'm also feeling so proud to all the students. There are many, but these are they did their best. Okay, so today I'm going to continue from where we stop at the last at the on the part 8. Actually, there are many changes. There are many changes in the previous slides, guys. So I will try to take one separate sessions for that all the updated one. Okay, so currently we are where we are. Yeah, at the last time we stopped here, and the part 8 and the part 8 we stopped here. Okay, so next one we're going to talk about the dexamethasone suppression test. Okay, now please try to take the Xerox or anything, or you can just if you are opening the laptop anything, just in the pad, just you have to take note down what you have to read. Okay, so actually this is mnemonic is by Akashi sir, but I'm going to teach you guys this one in the very simple one. Okay, but if you remember the mnemonic, guys, it won't work. Okay, just remember this one. Okay, so we are going to, this is the dexamethasone suppression test, guys. This is the how they are going to frame the question from here. See the read the question first. A male patient, chronic smoker, presented with cough, skin hyperpigmentation. During further evaluation, he is found to have high cortisol level. Oh my goodness! Even after admission of high dexamethasone. Okay, it means he. See, it is the ectopic case. Okay, so remember, I don't want to teach this one. Just I will teach this. Okay, remember, we are going to see why we are going to do this dexamethasone suppression test. First of all, you have to know because we have to suspect the Cushing disease. Okay, we have to know the Cushing disease. Either what is the most common cause of the Cushing disease? It is atrazonic. It is a atrazonic by it means what by injections. There are many RMP doctors in our village sides. For any small infections or for any small abscess, they're going to give directly. They're going to give the dexamethasone every time. Okay, so if you are going to take a more dexamethasone, more steroid, then what happens? Will in future you may have high chance of to getting Cushing disease. So you have to know the what's the reason for that one. Okay, you have to find out what's the cause of the Cushing disease. Either it is heterogenic cause, or either there is a pituitary tumor, or there is a lung cancer. So for to find these only, guys, we are going to what? We are going to do the we're going to do the this test. Okay, first of all, what is the screening test of choice? It is the 24 hours urine cortisol level. Okay, so actually it must be decreases. Okay, it is increases. Okay, so in the Cushing disease, guys, it will be increases. Okay, next one is the what is the injection of choice? It is the 1 milligram dexamethasone. Means what is the low dose? It is the low dose is the 1 milligram, that is dexamethasone low test. Okay, dexamethasone low dose. See here, test, you have to check the ACTH. You have to check the ACTH level. Okay, now see, what is screening test? It is the 24 hours cortisol level. What is the investigation of choice? It is the 1 milligram dexamethasone low, that means low dose. Okay, test. Then you have to check the ACTH level. Okay, now you have to check the ACTH level. If the ACTH level is low, okay, if it is low, then what? If it is low, then it will be favor to what? It will favor to yeah, it will favor to what? It is the region will be atherogenic cause. Okay, so so that you have to avoid the giving steroids. If it is still high, 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 then you have to perform the high dexamethasone suppression test. Okay, you have to find the high dexamethasone suppression test. Okay, why? If it is still high, then you have to check for the either why ACTH is high means either it may be by pituitary tumor or lung cancer. Okay, so in order to rule out this one, you have to do the high dose suppression test. So if it is still low, if it is low, it means it is due to pituitary tumor. Okay, if it is still high, if it is still high, then it's going to be it will be the ectopic ACTH. It means there is a lung cancer. Okay, due to lung cancer only, this ACTH is more. Okay, what lung cancer? It is the small cell carcinoma. Okay, now then this is what they are going to ask the questions here. Done. So low dose, high dose. Low dose, ACTH check ACTH level. Low, it means it is atherogenic cause. It means okay. High, it means you have to check either it is pituitary or lung cancer. If it is low, pituitary tumor. If it is very high, it's still high. It is the ectopic STH. So it may be due to the lung cancer, this small cell carcinoma. So it is still high here. Still high here. It means it's going to be what? Favorable to what? It is the ectopic ACTH. Okay. That is what amma? This one. It means it is going to be favorable for the small cell carcinoma. Done? Done. Next one, next one we are going to discuss over here. Let's come on. Desperation though, come on. Ay, yo, Mr. Perfect. And Mr. Perfect. Dun. Okay, done. Next one, how they are going to ask the questions here, guys. Remember, this is the what? This is the okay, now midbrain, pons, medulla. Midbrain, pons, medulla. So we are having how many? 12 cranial nerves here. So they may give the questions which cranial nerves are going to arise from the midbrain. What cranial nerves are going to arise from the pons? What cranial nerves are going to arise from the medulla? So you have to remember this one. Okay, remember this, which are from the mid from the midbrain, which are from the pons, which are from the medulla. You have to remember. And also they may give the image to label that one. Okay, so what is this? What the cranial nerve is this? You have to say third cranial nerve. Okay, you have to identify. Okay, now just please mark it. They may give this image. Okay, now image as for the like cranial nerve markings, or they may ask the what are the cranial nerves involved in this and also they will give the some case scenarios, guys, like okay, so they will give some case scenarios, so you have to know like what cranial nerve is functions of the cranial nerve. Okay, so you have to know everything. Okay, so next one, this is the example, guys, like this is the circle of Willis, and this is the two vertebral artery here, two vertebral artery joining to form the basilar artery, and this forms of posterior cerebral artery, and this is the posterior cerebral artery. Uh, this is the middle cerebral artery, anterior cerebral artery. Okay, these two forming, or this is the by this cerebral artery and the PCA, the posterior cerebral artery, is connected by a posterior commissure, and the middle cerebral artery is what going to form connected with the anterior commissure artery. Okay, so this is the these linings is called as this one circular Willis, Actually, guys, see here, this is the internal carotid artery here. Okay, now, but can you tell me this MCA, it means middle cerebral artery is going to form the circular villus? No, circular villus is not going to form, is not going to form the what? Circular villus. So this is the question there once upon a time they asked in the examination. Okay, just try to look on this one also. So this is the scalp dissection, guys. So please learn. These are the okay. This is your work. You have to know what are the layers. They will give this image. They will give this image, and they will talk about like what's the okay aponeurosis. So the first one is the what? Aponeurosis. The first layer is the aponeurosis, and the next one dura mater. Here is the dura mater, and the frontal is muscle here. So guys, like they're going to give this section of the head scalp. So you have to know, okay? You have to know, and they're going to mark the, suppose they're going to mark the this one, okay? And they're going to ask you a question. Okay, you have to know that this is the parietal branch of a superficial temporal artery. That's simple. First is the skin. Obviously, there is first the skin. There is a fascia, temporal bone, subcutaneous tissue, skin. Okay, you have to know the parts. The next one, this is the external ear. You have to know the parts, and also you have to know the like I already gave in my channel what's the in my channel like what's the nerve supply. Okay, what's the nerve supply of the pinna or only tragus and antitragus helix parts, a lobule. What's the nerve supply here? Please try to go into my group and try to find there. Okay, just know the parts, the name and their origin. Okay, so in the group I already shared all thing everything. So what the non supply. Okay, na? From this one, guys, this also, guys, you have to know about the midbrain. This is the thalamus. Okay, midbrain, midbrain, pons, medulla oblongata. Here, this is the cerebellum, corpus callosum, lateral ventricles here. So just you have to know the labeling. Okay, labeling is very important for the image based questions. Okay, this one also, guys, image based questions. So one MCQ will come, and also the I will mark the important points you have to remember. Okay, now just remember these points. Okay, whatever is here. So this, as you know, that this is the watama. This is the corpus callosum connecting the two hemisphere, cerebral hemisphere. Okay, now so this is the corpus callosum. This body forming this is the fornix, body of the fornix here. These are the two lateral ventricles. This is the third ventricle. This is the what, amma? This is the fourth ventricle here. So remember, this is the what? This is the C-shaped here. What is called is a caudate. This is the caudate nucleus. This is the caudate nucleus. Okay. This is the caudate nucleus C-shaped here, and this and also see here. This is the what, amma? This is the what? This is the internal capsule. This is internal capsule here. And remember, this is the lentiform. This is the lentiform nucleus. This lentiform nucleus. We have two parts: globus pallidus and the putamen. Okay, globus pallidus and the putamen here. Okay, so these are the things you have to remember. Okay, I think this is the everyone knows about this one. This is the pons. Okay, pons, thalamus, midbrain, this is the spinal cord here going to ending medulla oblongata. Okay, then these two are what? Cerebellum. Okay, so that's what you have to learn in the exam point of view. Okay, next one, so very good. This is so, and these folds are called what? Insula. That's it, the next one, here how the next one. Okay, so next one we are going to talking about this is the memory potential. How they are going to ask the questions here, guys. See, they are going to give this graph. Okay, they are going to give this graph, and they are going to mark. They are going to mark number 2. Okay, tell me what is number 2. Tell me what is number 4. Like this. So as you know, this is the resting position. So there is no memory potential here. Okay, main potential is more permeable. This is the resting potential. Okay, na. So, okay, na. Then this is the what? This is the contraction stage. That it means there is a depolarization. Depolarization is also called as what, amma? Contraction. Okay, na. So when it is contraction, there is what? There is a sodium. What? What happens? Sodium activation gates will open and the sodium will flows inward. That's how there is a contraction, nara. Okay, na? Contraction. Then there is a repolarization. Third phase is the what? Repolarization. Okay, na? It means what? Relaxing. Relaxation. It means what? Same against sodium. Sodium will be inactivate, isn't it? Then the fourth one is the what? Membrane hyperpolarization. Just remember what is happening, what is the influx and outflux efflux. Okay, just remember that one, and it will be going to be very easy for you. Okay, the next one you have to remember the some now fibers here, like C fibers, A delta fibers, delta fibers, A delta fibers, gamma fibers. Okay, so you have to know what's their function. Okay, na? Okay, na? A delta plane is very fast, but the C is slow. Remember, C is fiber is the unmyelated and very slow. They will ask which is the fastest one, which is the slowest one. Okay, na? What their pain and temperature. Location where is the accept cartridges. And there is somewhat receptors here we have in the medical receptor, Pacinium corpuscle, Messinus corpuscle, Ruffinic corpuscles. You have to know the what they are doing, the functions. Okay. So in 2020, I think they gave one MCQ from here, but they're not going to ask the simple questions. Okay. And the next one, guys, this is the sleep cycles. I think everyone knows this is the when the patient is awake, guys, there is the altered mental, active mental concentration. Obviously, the eyes will be going to open. So this is there is a what non-rapid eye movement. This is the NREM. Okay, the stage one will be like this one, guys. Okay, so like this one. Okay, like okay, someone is sleeping in the class. Okay, Ajay, okay, he will open. See if someone shouted, Ajay, yes, sir. It is the stage one. Next, stage two means what? Deep sleep. Someone like not all, but most of the patients, people will also do the teeth grinding. I remember my brother. He do this one. He will just grind teeth. Okay, they will make the sounds. Next, stage three is the what? It is like a stage three is the deepest non-REM sleep. Delta waves here the when bedwetting, sleepwalking, and night terrors occurs. Okay, now so in the stage three there will be what bedwetting, sleepwalking. Okay, now so I remember my childhood also I did bedwetting. So I don't know. I think it's what I got a one dream that I was doing like I was peeing on the road, but the reality is that I was peeing on the bed only. My goodness, that is the end stage and at what stage? N3. Okay, now then the last one is the REM, that is the rapid eye movement. This is last of motor tone. Last of motor tone here. It means what? The what happens, guys, if you go into the rapid eye movement, this is the REM sleep, guys. It means your hands will be like a flaccid. Okay, your hands will be like a flaccid. This is loss of motor tone, and that increase brain auto use, variable pulses, and there is extraocular muscles due to activity of the pyramid and pontonaticular formation. Conjugate gaze center may severe memory processing function while when dreaming nightmares and penile occurs. Remember the okay now see how they're going to ask the questions. So actually, guys, when we are in the deep sleep, in the REM sleep, guys, then what happens, guys, the brain wants to more oxygen that time, and also that time only we will see the dream. Okay na? And those dreams will be you will remember forever. Uh, meaning if you got the dream and you remember and in the early morning you're going to tell to your father or your girlfriend or your best friend, anyone, hey, today I got yesterday night I got dream ra. It's like I proposed you, or mom, I got success. Okay, now it means what? It means that you are in a REM sleep. Okay, if you don't get and you didn't remember your dreams, it means you are in the stage 3 only. Okay, just I'll also remember the not remember these, but remember that the waves, but the main important are these one. Okay, next one, a patient was lurching on one side. See here, what happens here is that see, okay now, okay, yeah, see here, we have in the gluteus medius and minimus. Gluteus medius and minimus. Gluteus medius and minimus is supplied by what nerve? It is the superior gluteal nerve. What's the function? Function is the abduction. Function is the abduction. Function is the abduction at the hip joint and stabilize the pelvis while walking. Okay. What happens when there is a injury to the superior gluteal nerve? Okay. What happens when there is a injury to the superior gluteal nerve? Will gluteus medius and minimus will work? No. Will they perform the abduction? Will they stabilize the pelvis? No. Then there is the patient will not do the abduction. Okay, na? That's why while walking he may fall down. He may fall down. That's why to take the support, he will lurch. It means he will bend one side. He will bend one side. See, this guy is bending one side and taking the what? Taking this leg support. Isn't it? Example see here guys, how they're going to ask the questions. See, simply they will give this. Okay, so see here, simply they will give this question. Okay, na? Simply they will give his simple. Okay, see, he was when he keeps right foot on the ground, the pelvis drops to the left side. Here, see here, always see, always on the same side. See, the injury is happening on the right side. Here it means he shifted on the right side only, which means he will take the opposite leg. Okay, na? He will take the opposite leg support here. See, simply they will give this question, or if they want to confuse you, they may also ask that a patient has the superior gluteal nerve injury, and he is having he is doing the lurching gait, and he is walking like a lurching gait, and he want to test. Okay, na? That's why he told to he told to walk. Okay, na? It means what? It means what is doctor is observing, what doctor want to do. Okay, now it means he was checking the abduction. It means he was checking the abduction. Okay, now simply see, simply if you don't understand, simply remember. So as the doctor knows that this is the going to case of the this is the lurching gait, and as you know that there is a superior gluteal nerve injury, and what happens, what moments is going to affect, that is the abduction. Okay. Okay, done. Come to gluteus maximus. It is caused by what is it nerve supply is the inferior gluteal nerve, and action is the what? Extension at the hip, the external rotation of the hip, done by gluteus maximus. This is also called that Tendelberg sign. Okay. The next one, simple one. No one is going to ask this question because it's very simple. See here, but remember in the anesthesia department, in the anesthesia guys, they are going to ask what are the layers pierced during the lumbar puncture, right? It's not lumbar puncture actually. It's going to be not lumbar puncture, which is the dural and epidural. This is the, sorry for this one, remember here, this is the going to be what? Dural and epidural. anesthesia, anesthesia. Okay. See here, guys, when we are doing, see, okay, remember here. See, what are the layers you are going they are going to pass during giving the, so I think most of you guys are have you ever went to ot guys? So like we are going to ot first, they will decide the what to give the like either essay, either spinal anesthesia or ga. See here, this is the see this the umbilicus here, above umbilicus, okay, now above umbilicus everything you have to give the ga, and below umbilicus you have to give the, and below umbilicus you have to use the spinal anesthesia. That is the dural. This is the dural anesthesia. Okay, now the dural anesthesia. See that is the spinal anesthesia. Okay, now sorry, this is the spinal anesthesia. Okay, this is the spinal anesthesia. Okay, it's the spinal. This is spinal and epidural anesthesia. See what is the? I want to share one thing, guys. What is the meaning of the epidural anesthesia? See here. See, if you give spinal anesthesia, guys, what happens here? If you give spinal anesthesia, it means they're going to wear at the level of weight L3, L4. They're going to what? They are going to give the injection. That is local anesthesia. They are going to use that bupivacaine and lignocaine are the most important. These are two one. These two are they are going to use the for the spinal anesthesia. Okay, na. So if they give these guys, then what happens is there is a complete loss of motor and sensory. If you tell the patient to lift the leg, he is unable to lift the leg. When coming to that is the epidural anesthesia, guys, what happens here? Here here only, sensory, okay na, here only sensory receptors are lost, okay na, meaning there is no pain, but motor senses receptors is spared. It means when you tell the patient to lift the leg, he will lift the leg. That's what the epidural anesthesia. It was done in painless labor, because if they are doing the painless labor, guys, they may tell to the patient that please put your leg like this. It means how? If they give the spinal anesthesia, they does the patient will lift the leg? No. That's what the difference is here. Okay, so while doing the spinal anesthesia, guys, here, so these are the layers where so these are the layers that we are going to pierce during that procedure. Okay, now the first one is the what? The skin. The next one is the ligament called as what? What is the ligament? Supraspinous ligament. What is the supraspinous ligament? Then there is a next one is the there is the interspinous ligament. Then fourth one is the ligamentum flavum. Then fifth one is the epidural space. Okay, na? So it means we have to puncture where? At the puncture only at the level of the epidural space for the epidural anesthesia. Okay, na? Got it, huh? Okay. So for the for the epidural anesthesia, you have to puncture what inside until only the epidural space. But okay, so the next one is the dura mater here. The dura mater. The next is the arachnoid mater. The last one is the subarachnoid mater. So we entered into the subarachnoid mater where there is a production of what? Production of a CSF. Okay, now. So we have to give until subarachnoid space. Okay, now. So here guys, that's how they're going to talk about the uh they're going to give the questions from the layers pairs during the spinal and the epidural anesthesia. Got it? So you have to remember these. Okay, na? You have to remember these layers. Okay, na? Done. Next one, so this is the ASA classification. So this is the anesthesia, American Association with American Anesthesia Association. Okay, American Anesthesia Association. It means what? It means you have to check. Like see, before doing any procedure, first of all you have to do the pre-anesthetic care. That is PAC. Okay, na pre-anesthetic care. From where that guys, the doctor will advise some tests like LFT, RFT, 2D echo, ECG, everything. It means if there is nothing, guys, if it means if the patient don't have any comorbidities, it means it is the patient will come under healthy ASA1. It means the patient has no comorbidities like BP, sugar, nothing. And remember, ASA grade 4, ASA 6 means what? This patient is the brain dead patient. Okay, na? See, 1 is healthy, 6 is dead, brain dead. ASA2 means what? Mild systemic diseases, no functional. It means they having the BP sugar, but it's controlled. Okay, simple language. Next, ASA3, moderate systemic diseases with functional limited. Function is limited. This means, see, the first one is good, second one is mild, third one is moderate, fourth one is severe diseases. It means the patient might have chances to lose their life. It means ASA4. The next one is the morbid, but next one is the 6 is a moribund patient, means about to death. About means they will not give the surety that that the patient might be able to survive or not. Okay, now it means that's what they're going to give the questions in the exam. So they're going to give like cases like there is one patient, he's having the BP, sugar, LFT and RFT are there, and he was using these medications. It means and it means by seeing the result, you have to know that okay, so okay, even though this patient is having the BP, sugar, and he's using these medications, it means the results are normal. It means it is under control. So it is here under SA2. That's it. Next one, the Malampati score. The Malampati score is a score to it is the test to assess the airway. It is the test to assess the airway before doing the surgery. It means guys, you have to. It means if there is any serious illness, if there are any serious complications during the surgery, it means for the easy of the intubation, you have to do this. You have to do the Malampati scoring here. First of all, you have to tell the patient to open the mouth. Ah, okay. You have to tell the patient to put to the tongue. Ah, okay. So you have to see if there is, if you can remember the mnemonic is push here, push. P for okay na, see the pillars here. Okay na, see the pillars. Okay, which means tonsils here. Okay, next see that, see the uvula here. Okay na, see here your soft and okay, hard and soft palate here. Okay na, soft and hard palate. So you have to see if everything is normal, guys. It means this guy is under the class 1. It means it is the best to do the intubation. Next one, next one. If there is no pillars, see if there is a pillars, it means there is he having the tonsils are hypertrophied. It means guys, and only tonsils hypertrophied and everything is normal, is going to be the class 2. And then guys, okay, push PU is the done here done. Okay, See, and if there is only soft and hard pellets are visible, it means he's under class 3. It is very hard to do the intubation, and class 4 is the, oh my god, we can't do anything. Okay, this is how they're going to ask the questions here. And also see the here in the, I think you guys seen these one, these cylinders, guys. This is the black body with the soul with the head, with head water, black body with the with shoulder is what, white shoulder. It is the what is obviously is going to be the what, your oxygen your oxygen here. Okay, blue body, white is one is the air. It is the next one black body. See here, this is the nitrous this is the nitrous oxide. See, nitrous oxide. So nitrous oxide is the what, blue color. Okay, now remember this is the pin index so okay, this is the pin index. What is the pin index? So pin index, this is the pin index. Pin index number. Pin index number means what so in the OT guys, in the OT guys, in the ventilator machine, there is a pin index number like this one for the for the everyone, everything. This is for the oxygen, this is for the air, this is for the for the N2O. For everything guys, there is a pin index number. So for the oxygen is the 2,5, and the air is the 1,5, and the nitrous oxide is the what, 3,5. Okay now, for the nitrous oxide is the 3,5. So by this guy's number, for everyone, like to avoid any mistakes while we are in the emergency, guys. Okay, so that's why everything we are having the a particular number. Okay na, so everything. So this is the, like, so this is the oxygen here, okay na, oxygen. So there is a pin index number 2.5. And also there is a and you have to check whether there is sufficient oxygen in the in the OT or not. Okay, just remember what is the pin index, PI index. Pin index number for the oxygen is the 2,5, air 1,5, nitrogen oxide is the 3,5. Okay, the next one, these are the pipelines. Air is what, black here, air is black, oxygen white, nitrogen oxide blue, vacuum yellow. Remember this blue means what, Neela. Neela rangu. Okay, this is the Neela. Neela means what, it is the blue. It means Ni for nitrous, Ni for Neela means what, Neelo means nitrous oxide. Vacuum yellow, air. On the ECG, on the X-ray, chest X-ray, air will be what, black color only. So remember that's a black color. Oxygen white. Okay, done. So this is the oxygen water, black body with white shoulder, or nitrous blue body, carbon dioxide what, carbon dioxide, it is the gray body, and helium is the brown. Okay, done. Next one, right? Okay, see, yes, it is 38-year-old old man undergoing a nerve block for lower injuries as a and the Bupuyok, and he had rapidly confused tremors. Okay, see here. What happens is that, see, this is the Bupuyok, okay, na? So this is the Bupivacaine, okay? Bupivacaine is the most commonly local anesthetic used for the spinal, used for the what? Used for the spinal anesthesia. Okay, na? Bupivacaine is the most common. See here, okay, na? For the spinal anesthesia. So this is good for the what? This is good for the spinal anesthesia. What happens, guys, when there is a when this one accidentally they're going to pierce in the what, in the artery. Okay, na, pierce in the artery, or they're going to give a lot of bupivacaine. Then what happens? This is the bupivacaine is the most toxic. Is the most cardiotoxic. It is the most cardiotoxic. Bupivacaine is the most cardiotoxic drug. What happens if they're going to give accidentally into the artery? It will causes the what? It will causes the cardiac myopathy. It will lead to ischemia also. because it is the most cardiotoxic. It won't like hot. So if there is a what? That's why he is developing what confusion, tremors, okay, cardiovascular instability. Then you have to immediately how to give the 20% intralipid solution. Okay, na? See, 20% intralipid solution, it will what? It will dissolve the bupivacaine into the normal saline, into the normal solution. Okay, now you have to give the intralipid. The next one is the a 35-year-old minor surgery in Bangalore Center is assisted declaring IV induction agent for the recovery post procedure, allowing for the some discharge. Which anesthesia agent preferred so see, it is the quick recovery. It means they're asking about the daycare surgery. What? They're asking about the daycare surgery. It means the number one is the propofol. Number one is the propofol. See here, propofol is the GABA agonist. Okay, the GABA agonist. And also remember, propofol, it is the most commonly given. It is the most commonly IV anesthetic drug, which is given. What is the IV, and this is the most painful also. What is the content? The components are the propofol is a milky white. Okay, it look like the milk. And what are the components? It will made with the lecithin, soybean, egg also. That's why if you have a egg allergy, you have to avoid the propofol. Okay, na? It's the look like what milky white. Okay, that's what you have to remember. And there are many, and there are many like we are having the ketamine, thiopentanol. So we will discuss in the separate topic. Okay, na? I already shared in our Telegram channel. Okay, na? But your work is that guys how to also remember the. Please read about the ketamine, thiopentanol also. Ketamine and thiopentanol also. Okay, na? Done. Next one is this is the CPR. So this is the CPR. You have to know the CPR for that one. CPR. Okay. So for they asked about the ventilation ratio in the adults. It is the what? It is the 30 to it is 30 to 30 times you have to know. Okay. This is the 30 is to 2. Okay. Now compression is the 30 is to 2. 30 is to 2 is for the what? For the adults. For the neonate is the 3 is to 1, and for the pediatric is the 15 is to 2. Okay, na? This is the question they are going to ask, and also please try to read these are some basics. There are some basics about CPR. Okay, na? What to do in what conditions you have to do the 3 to 1, and how much time to compress. Okay, please once have a look. I already shared one video in my Telegram channel. Okay, na? Just try to watch this one about the CPR. Next, remember some important here. I remember here are some important one-liners from the anesthesia. Just try to read these all, and remember they have the circuits. See here, we have a mapulsion F type of used in the pediatrics. So this is the Jackson Rip circuit used in the pediatrics. So how to remember this one? If you can't F, then how you are going to do produce the baby? I think you know what I'm telling. So it is the mapulsion F. Mapulsion D, it is for the what? It is used in the control in the adults. Okay, it is used in the adults, D adults. Remember, atracurium, cis they will go to Hoffman elimination. It means, guys, they are not going to metabolize in the liver and the kidney. They are going to metabolize in the what plasma. So that's why it is safe during the liver and kidney surgery. Safe in children, sevoflurane. So these are the pre-op. So remember, breast milk you have to avoid 4 hours prior to surgery, and formula milk 6 hours. Full milk 8 hours before surgery, and light milk 6 hours before surgery, and water 4 hours before surgery. Okay, done. The next one is these are the post dural puncture headache. After these are the most common complications. This is the post dural puncture headache. Okay, na? See what is the most here. I will try to remember you. See, this is the introp. Okay, this is the, remember, this is the introp. So this is the introp. It means during the operation. This is the post-op. Oh, yeah, sorry. Okay, this is the post-op. Okay, this is during surgery, after surgery. Okay, na? See, during surgery, what is the most common complication? It is the hypotension. It is the what, amma? What is hypotension is the most common complication. First complication. Second is the bradycardia. Second is the bradycardia. Next one. What is the most common complication after the post-op, after surgery? It is the, what is the urinary incontinence. It is the urinary what? Urinary incontinence. Okay, na? Urinary incontinence. Okay, na? Urinary incontinence. Okay. Now, second most is the, and the second most is the headache. The second most common is the headache. Okay. Headache is the second most common. Done. Done now. So these are also the important MCQs. What the most common complication of the spinal anesthesia? What is the most common introp complication? In say introp, it means going to hypotension. Second most common is the bradycardia, and the what is the most common complication post-op? It means the first one is the urinary incontinence, and the next one is the what, headache. See, post-dural headache occurs. Why? Because see, since CSO, okay, we are what we are doing. We are during the spinal anesthesia. We are going to what? We are going when we are going to, when we are doing the puncture, and we are going to do the puncture. See, little few drops of the CSF may leak out. Obviously, na, it will leak out, na. CSF will leak out, na. So CSF will leak out. Okay, na? Because of that one leaking, there is a reduced amount of CSF from the brain also, na. So there is a reduced CSF the brain also. That's why there is going to the, we are going to have the what? We are going to have the headache here. That is called the post-dural puncture headache. Means post-dural puncture headache. So what we have to do? We have to do the dot. There is a dot tablet. Use it. It is the made up of the NSAID plus the caffeine. You have to give the coffee to the patient, and you have to do the posture changes. Meaning, if you are going to do, if you are going to keep the in the standing position, it means what, the CSF will flow down only. That's why you have to make the patient to sleep in the supine position. Okay, that's it. Done, 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 done. The next one is the heat. Remember, this is the psoriasis. This is the psoriasis. Okay, now, actually, what happens, is why, what the hell is this psoriasis? Actually, remember, reduce here, reduced epidermal turnover. Okay, now, reduce the epidermal turnover time into what? What? Actually, it will, what time? Reduced epidermal turnover time to 4 days. Normally 56. Okay. See here. Actually, Ram, see here, there is a reduced epidermal turnover time into four days. Actually, there is a epidermal turnover. It must be done up to 50 days, 56 days. Normally, the 56 days, it will be what? There is a formation of the new skin. But what happens here is that within 4 days only, it's going to turn over. It means meaning there are some immature cells also that are going to form very fastly. That's what the main pathology here. The epidermal turnover time actually is a 56 days, but in psoriasis it's going to be 4 days only. Okay, so which leads to the hyperproliferation of the keratinocytes. And also see there is a Monroe's micro abscess in the stratum corneum. They in the questions they may in some questions they will ask like this. There is a Monroe's micro abscess, yeah, are present. It means they're asking about the what? They're asking about the psoriasis only. Okay, Monroe's micro abscess. And also the Kogos spongiform pustules in the where in the malphizian layer. Okay, now it means Monroe's abscess and Kogos spongiform pustules are seen in the psoriasis only. Okay, now the TH or helper cells, what one is the predominant immune response here. No itching, and it will exacerbate in only in the winter season. Okay, na? There is a aspect sign post. It means there is a pinpoint bleeding here. So, okay, now if you are going to scratch the surrounding tissue, guys, it's going to be what? Bleeding. Okay, now there is a keenness phenomenon also going to positive here. Okay, na? So that's what you have to remember about the psoriasis here. Okay, na? Psoriasis. Okay, na? These are the treatment for that one. Okay. Remember a simple question they are going to ask. What is the either they are going to give this image, they are going to ask what is this, they are the silvery white scales. It means they are going to asking about the psoriasis or the epidermal time turnover time, and the Monroe's abscess causes spongiform, the aspiside positive where, and keenness phenomenon where. Okay, na? And what are the what is the treatment methotrexate, we have to give that one. Next, remember here, remember the keenness. Remember here the keenness phenomenon. Keenness phenomenon, true keenness phenomenon, where we will see in the, we will see example the mnemonic is the plavi. If the plavi means P for psoriasis, lichen, and the V for vitiligo. The lichenification. Okay, na? In the psoriasis, lichenifications, and there is a vitiligo. We'll see the true keenness phenomenon. Pseudokibnus in the at the watch and the molluscum. Okay, na? Done this one. Remember, in the leprosy type 1, see, remember leprosy type 1 is a type 4 hypersensitivity. Leprosy type 2 is a type 3 hypersensitivity action. And also remember, this is the gutted psoriasis. This is the gutted psoriasis. Gutted psoriasis. So gutted psoriasis, guys, they will give this image, and it means they are asking about the diagnosis. This is the raindrop. This is the raindrop process. Yeah, the raindrop rashes. Okay, na? Raindrop rashes. And also, gutted psoriasis is due to the, if the patient is having sore throat, meaning a child is having suffering from the sore throat, and he developed the rashes here. There are the rashes at the back. When you are going to examine and you see that, okay, there is a raindrops are present, meaning you are going to ask the patient whether he is having sore throat or not. If the patient came to you and they are showing only, doctor, my child is having this, my child is having these rashes. So we'll get one idea, okay, you have to ask the history. Okay, is there your child is having the sore throat? You say yes, okay, then it's going to be favor to the gutter psoriasis. It means gutter psoriasis here is going to be by bacteria. Okay, na? That is, you have to give the streptococcal antibiotic is penicillin or amoxicillins. Okay. Next one is the pustular. Next one is the pustular psoriasis, where there is a legs of the pustules here. Okay, na? Legs of pustules severe with fever, and there is a active dermatitis. Treatment will be acetating. Okay, done. Next one, this is the Richter syndrome. This is also called a reactive arthritis. There is a Alport syndrome. Okay, na? Alport syndrome. In my group also, I also discussed about the differences between some important terminologies. Okay, na? See, this is Ritter's and Ritter syndrome. I already discussed. So try to check out our group. Okay, just search in our group Ritter's and Ritter syndrome, and Alport syndrome also. I discussed very neatly. Okay. So these are the genital warts, also called as what? Condyloma lata acuminata, and a condylolata mata and acuminata. Okay, acuminata. Okay, here in the HPV, and the Lata is where we see in the syphilis. Okay, done. 1 to 4 is the warts. Yeah, warts. Okay, HPV. Okay, HPV types here. HPV 1 to 4 is the most common cause is the from the warts, and the 611 causes the what? 611 causes the anogenital warts and also laryngeal warts. Okay, remember here, this is the Pemphi. This is the pemphigus. This is the pemphigus. So here, what happens here is that see interdermal autoimmune. Okay, and okay. See here, we have the pemphigus foliaceus and the pemphigus vulgaris. Okay, now pemphigus foliaceus and the vulgaris. Remember, these two are important. See, in the questions, you have to read that one. You have to read very carefully. Okay, now you have to read very carefully. They will give that one. Uh, Mhm, mhm, mhm. Okay. Pemphigus foliaceus and vulgaris. See, this is the desmo. See, in the pemphigus foliaceus, there is a desmoglobin. This is desmoglobin 1 is present. And what in epithelium is involved? It is the stratum granulosa superior bulle. Superior bulle. Let me 1 minute, raw. Give me 1 minute. I also confused here. See, foliaceus and wait, wrong. There's only one difference, Ra. Okay, na? Wait long. One differences. Okay, Newsom. I I didn't revise actually. So don't worry. Can see this. Oh, yes. Array versus. Okay, okay. Pemphigus vulgaris. Yeah, Pemphigus vulgaris. Okay, most common. Pemphigus vulgaris most common form buccal mucosa from vulgaris. Okay, see here. Yeah. See here. The only important one is the between the pemphigus foliaceus and vulgaris is the pemphigus vulgaris. What it involves the desmoglobin desmoglobin 3, and this involves the buccal mucosa. Okay, na it involves the buccal mucosa. Okay, na it involves the buccal mucosa. It means it associated with the what associated with the oral lessons. Okay, na? That's what you have to remember for the exam point. Okay, na? Tell me, pemphigus vulgaris, what it involves the desmoglobin 3, and it involves, they will give the history as the, there is a, what, there is a oral mucosa, there is a oral lesions are associated with the pemphigus vulgaris, and if they don't mention the vulgaris like oral lesions, then you have to mark the pemphigus foliaceus. Okay, it is the DSC1. Remember, foliaceus F means first means what? It is the foliaceus. It means DSC1. Okay, now done, na? Done. This is lichen planus. There is a severity bodies here. Lacy reticular variant. Next one, da. Okay. Sorry for that one. I didn't revise that one. Okay, see, actually since 2 years, I think since 2 years, from this PDF only, guys, there is questions in from this PDF only. There are many questions in the exam. Okay, now, so the last time they gave this one, melasma, the same question, melasma first, and this one, red coral fluorescence, that's the erythrasma. Madura foot is given, scabies is given, castle neck is given, everything raw. Okay, na? Just try to once take the screenshot or just take out the printout and try to find out, and also try to write down the all the importance, how we are going to remember, like how we are going to remember these images. Just try to figure out, okay, na? Just by heart the images and the um, mm, clinical importance, okay, na? This is also the given echodermatitis enteropathica, zinc deficiency, alopecia areata, okay, na? Then these also are important. I did a lot of work, okay, na? So I typed everything in the image itself, okay, na? Just try to read, okay, try to read everything is important. No need this, no need this. Granuloma setup, I want to okay. Just try to, in a free time, try to revise all the images. Try to revise all the images. Okay, na? We don't have time to discuss more here. The next one, here, see, we are having a, okay, we are going to, okay, we are starting this, okay, done. Okay, then, sister here, dermoid sister, collection of skin elements. See here, these are the, what do you call that? These are the image based questions. So they will give this image at the canthum. Okay, this is the lateral canthus of the eye. At this area, guys, they are given to the swelling. This is the fluctuating. This is a fluctuating swelling. So this is not going to be any abscess. Okay, now any furuncle. Okay, this is going to the cyst. Okay, now how we are going to it is lipoma or cyst. Tell me, this is your work. Just try to differentiate between the how we are going to differentiate between the cyst and lipoma. Okay, this is the dermoid cyst. Why is it dermoid? Derma means what? Dermoid means skin. It means skin elements in the work collection. Okay, there is a fluctuating swelling. What is the most common site? The lateral canthus of the eye. The treatment is the surgical excision. This is sebaceous cyst. This is the sebaceous cyst. Okay, now what is this? Is sebaceous means what? There is a blockage in the what of the hair follicle. With the blockage of the hair follicle, you have to do the surgical excision, a cut. This is ranula. This is ranula. Okay, na? Ranula means what? The mucus extravasation cyst in floor of mouth due to blockage of what gland here? Sublingual gland. Sublingual gland duct. Duct what? Sublingual duct. This is also the fluctuating swelling. There is a transdimensional test is positive. It also positive in the where in the hydrocele also. Okay, na? So the best one is the surgical excision of the cyst and sublingual gland. Okay, na? These are the what all types of ulcers and the examples you have to remember. Okay, na? I don't want to discuss here. Just remember the which is the sloping edge, which is the punched out lesions. Punched out is the undermined here ulcers, rolling edge ulcers, okay, averted ulcers, edge ulcer, and what are the examples you have to remember. One MCQ here and one MCQ here will cover everything. These are the also the questions. This is the all-time one questions are important. This is the venous ulcer, arterial ulcer, neuropathic ulcer, pediatric ulcers, marginal ulcer is associated with the burning. Okay, now remember this. The next one is the here remember a 30-year-old primigravida at the 39. Okay, read the questions. Okay, 30 years old primigravida. Okay, 30 weeks has been completely dilated, pushing for 3 hours. Oh my god, pushing for 3 hours. Fetal at 100. Okay. Patient service is completely dilated and FH. The fetal bones are at the -3. Oh my god, she was pushing. It means meaning they are pushing. It means see Primigramida 30 weeks has been okay na weeks has been completely dilated and has been pushing what? Pushing for 3 hours. They're pushing for 3 hours, but still still the fetal bones are at the -3 station. It means you have to reach at the plus 1 0. It means still on the -3. They're pushing for the 3 hour. They are still at the -3 only. It means you have to directly do the cesarean section. Meaning okay na? They are in the -3 only. Okay na? -3 station. If they tell that they're pushing and they the fetal bones are at the 0 or +1, it means it is favorable for the NVD. Okay na? That's what you have to remember in the questions. Okay. Next one is the woman at 32 weeks pregnancy pregnant with the BP 170. Okay. There is a urine protein +2. Okay. She complained of headache, blurring of vision. Oh my goodness. She having heading and see how they're mentioning. See, they're mentioning that she having the headache and blurring of vision. Oh my goodness, what is this, Ra? Okay. See, why they're giving this headache? Why they're giving this blurring of vision? You have to think. You have to think, Ra. It means they're asking about the impending eclampsia. What the triad is the epigastric pain. It means having the nausea, vomiting. There is a headache and seizures. There is a visual disturbance. This is the impending eclampsia. If there is no blurring, there is no blurring of visions. There is no headache. If there is no epigastric pain, it means she's going to the eclampsia only. Right? So this is the case of the impending eclampsia. For that one, you have to give the MGSO4 first with the BP, because the BP is 170. You have to give the BP. You have to give the MGSO4. Okay, MGSO4 and the Livitrol for the BP, MGSO4 for the eclampsia, and you have to do the IUL. Okay. The next one is the management of the eclampsia. Eclampsia. See here. For the management of the eclampsia, guys, remember simple thing here. Okay. Remember, what is the regimen you are going to use? You are going to use the Pritchard regimen. What is the regimen? Pritchard regimen we are going to use. Okay, that is the drug of choice is the MGSO4. What is the drug of choice? MGSO4. What regimen? Pritchard regimen. Okay. See here, in 1 ampule of the MGSO4, there is total 2 ml solution. Okay, na? In 1 ampule, how much ra? 2 ml solution is having how many grams? Having the 1 gram of MgSO4. It means that this is the ampoule here. There is a 2 ml of the solution. In that there is a 1 gram of 1 gram of MgSO4. What is the loading dose here? It is the 4 gram. 4 gram IV over 4 minutes immediately. It means when there is eclampsia, you have to first of all, you have to dilute. First of all, you have to dilute the MgSO4, magnesium sulfate. How much? What the loading dose is the 4 gram. If you want 4 gram, then how many ampule you required? Obviously, you will require how many? 8 only, da? Because 2 ml having only one, it means you want 4 ampoules. You want 4 ampoules. It means how many? It will total how many? 8 ml. Okay, 8 ml. 8 ml is the drug plus 12 ml plus 12 ml normal saline. Okay, plus 12 ml normal saline. Okay, now so total how much? 20 ml. Okay, so total 20 ml is required. So, okay now. So you have to total 20 ml. You have to give within 4 minutes. You give the slow plus push, and also immediately followed by 10 gram. Okay now. So if you want the 10 gram, if you want the 10 gram, then how much ampoules you required? Tell me. 20 ampoules, isn't it? So 20 ampule what, amma? 20 ampoules of what? 20 ampoules of 20 ampoules of okay, we want 10. So to 8 ampoules means 4 gram. Total to 20 ampoules we required. 10 ampoules, so two, okay, 1 gram, so 1, okay, 20 ampoules you require. So you have to give the, you have to load the 20, you have to break the 20 ampoules. It means you have the 10 grams. We'll get the 10 grams of the 10 grams of the whatever 10 grams of the MgSO4. That one total is the 20 ampule. So total is the 20 ml. So what happens? You have to give the 10 ml in one buttock and 10 ml in another buttock. You have to give. Okay. The next one is the for the maintenance dose. For the maintenance dose, you have to give what? You have to give how much? 5 grams. Okay. IM where every 4 gram, every 4 hours. Okay. Na? See here, this is the IM. Okay. Na? This is IM. So no need to, so no need to, so no need to, so no need to add the NS. Okay. So no need to add the NS. Directly you can give the what? Directly you can give the IM is so 5 gram here. Okay. So the maintenance dose is the 5 grams. Remember this. No need to remember the how. No need to remember 2 ampule 2 ampule में कितना होता है कितना नहीं होता है ठीक है. No need to remember that one. Remember the loading dose 4 gram followed by IV and followed by IM how much 10 gram. Maintenance is the 5 gram. That's it. Therapeutic range is the 4.7. So while giving the magnesium sulfate gas, you have to monitor. You have to monitor. You have to monitor the MgSO4 concentration in the blood. So before giving this one, you have to maintain. You have to check the deep TK, the deep renal reflex and urine output 100 ml. It must be 100 ml in 4 hours, and expected rest must be more than 14 beats per minute. Okay, breath. So if it is toxic, guys, then what happens? You have to give the calcium gluconate slow IV. Okay, na? So what is the first sign? What is the first sign that we are giving more MgSO4? It means there is a loss of knee jerk. Loss of knee jerk is the first sign. Next one is the respiratory distress. If the level is more than 12, paralysis more than 15, and cardiac arrest more than 25. Remember this simple one. One MCQ for sure. Management of hypertension in pregnancy. First is the labetalol. Okay. For the chronic hypertension, you have to give the methyl-dopa. For the refractory hypertension, you have to give the sodium nitroprusside. Okay. Remember, ACE inhibitors, ARBs, diuretics are contraindicated in the pregnancy, but diuretics you can give, but after 20 weeks only. Aspirin for the prevention of the pregnancy-induced hypertension, and if the patient is asthmatic, you have to avoid the beta blockers. So that's why you have to give the CCB, calcium channel blockers, mainly nifedipine. Okay, done. So these are the differences. You have to remember what is preeclampsia, what is chronic hypertension, and what is eclampsia, preeclampsia. Just remember just study the differences. Okay. So next one, this is the case of this is the placenta previa and abruptio placenta. Remember, in the placenta previa, there is a bright red color bleeding. There is a painless bleeding, uterus soft and non-tender. But in the abruptio placenta, this is abruptio. This is the dark red color bleeding, pain, history of abdominal trauma, and hard tender uterus. Okay, na? Treatment is you are going to give the McAfee and Johnson regimen patient, and we will have the here concealed abruption here. Okay? There is a clots formation. There is a clots formation here. Yeah, you may do the exploratory laparotomy here. Next one, this is the ectopic pregnancy. So, what is the most common site for the what is the most common site? It is the ampulla. Okay, and also what is the and also what is the most common site for the ruptured pregnancy for the ruptured active pregnancy is the isthmus. Is the isthmus. Okay, what is the triad? Abdominal pain, amenorrhea, vaginal bleeding is the triad of the ectopic pregnancy. For the management case, they ask you how to do when what are the surgical indications when the unruptured ectopic pregnancy. Okay, now when the unruptured ectopic pregnancy, sac is less than 4 centimeter, beta Hcg must be more than 500, and fetal activity must be absent. So these are the conditions for the management for the surgical management. Okay, na? For the conservative, how to do the drug of choice is the methotrexate. So methotrexate you have to. So methotrexate is given based on the beta Hcg level. So try to read this line. Okay, so these are the important terms you have to remember. So diabetes in pregnancy, so diabetes in pregnancy, remember here diabetes in pregnancy, where is that? Okay. See here diabetes in pregnancy. See, remember the main important one, okay? How they're going to ask one. So first of all, diabetes, okay, in pregnancy. See, you have to repeat the it is more common during the 24 to what weeks 24 to 28 weeks of gestation. Okay, I'm just telling how the questions are framing. Okay, first of all, diabetes in pregnancy at what weeks? 24 to 28 weeks only. Okay, done. The next coming to here, okay, coming here. What is the first line treatment? It is the obviously it is going to be insulin only. First of all, you have to give the insulin. Okay, na? The only drugs approved are the glyburide. Okay, na? It is the glyburide. But in pregnancy, we'll give the insulin only. Okay, na? We'll give the insulin only. Okay, na? Next one. What is the most common malformation? It is CVS. Most common malformation is the CVS. Most common congenital anomaly, VST. Okay, now we remember my questions here. Remember carefully how they are going to ask the questions. First of all, this one done now. Next one. This one was the 75 grams of the glucose is given. I think everyone knows for the postprandial. Okay, now you have to DIPSI scan. Okay, now for the DIPSI scan, how much? For DIPSI scan, how much they are going to give glucose? 75 grams of glucose we will give and tell the patient to come after 2 hours. Okay. Next one, see, insulin is the first choice, or if you want to give the tablets, but the most important one is the glyburide. What the most common malformation is the cardiovascular system. Congenital anomaly, VST. Most specific overall, it is the sacral agencies. Fetal complications such as fetal hyperglycemia. Macrosomia means weight is more than 4 kgs. There is chance of the shoulder dystocia, and they may have the abortion also. Okay, na? So that's what you have to remember in the diabetes in pregnancy. Remember the management here. Gestational diabetes mellitus, control with diet, continue pregnancy more than at 30 more than 39 weeks. Control on medications, continue till 38 to 39 weeks. Overt diabetes control on insulin, you have to do the induction of liver at 37 weeks. Overt uncontrolled diabetes, You have to terminate the pregnancy by 34 weeks only. Okay, that's what you have to remember here. Next, these are the important signs. So last time they asked the Hager sign. Hager sign in the it's already in our exam. So remember here, it's already in our exam here. So okay, so the Chadwick sign here, Chadwick sign, also called as Jacquemer sign. This is the bluish discoloration of the vagina at the cervix at what 6 to 8 weeks. Please try to correlate. Please try to correlate with the what do you call that? Try to correlate with the images. Okay, na? Just go to Google and try to add the images here. Okay, I forgot to images here. Then just try to correlate with the images. What's another sign? Fertility in the latter phonics we'll see at a eighth week. Goodell sign, softening of the cervix, 6 to 8 weeks. Hager sign, softening of the isthmus at 6th week. Fetal movements can be felt by mother at 16 to 18 weeks in multigravida and for 20 weeks in the primigravida. Braxton Hicks sign, it is irregular painless contraction palpable after 16 to 18 weeks. Remember this one. Try to see the images. Images are very important. Next one, this is the lochia after the delivery. There is a what? Bleeding, that is the lochia. This remember how to remember this one. This is the Ropis, RS, RSA, Sirupis A. It means rubra, serosa, alba. Remember the color red, pink, white. At what day? Postpartum day 1 to 3, 3 to 4, 3 to 10, and 10 to 14. Okay, now. So what is the color and what is the composition? You have to remember. Remember, this is the Leopold maneuver, first maneuver, second maneuver, third and fourth maneuver. Just here is the everything here are documented everything. Remember, while doing the fourth manual, that is the pelvic grip. For the pelvic grip, you have to face the patient feet. Okay. The first one is the fundal grip, umbilical grip, the poly grip, and the pelvic grip. The fundal grip what determine the fetal part, either it's the occiput or this one. Okay. Next one, you're going to you have to face the human's head, everything human's head, but the fourth one you have to face the humans, you have to face the patient feet at the feet. Okay, now the next one you are doing the what back we are palpating the back of the we are palpating the back of the fetal. Next one is we are doing the engagement, either the baby is engaged or not. If the baby is engaged, then only we'll perform the fourth maneuver. Okay. Next one, this is the shoulder dystocia. This is the shoulder dystocia. So shoulder dystocia, the most common. What the most common cause? It may due to the so shoulder dystocia may lead to Op's palsy. I think everyone knows C5 C6. Op's palsy. It leads if you still push the baby, if you are still trying to push the baby, it may lead to Op's palsy. There's a brachial plexus injury here. So for the shoulder dystocia, defined as shoulder do not deliver within 1 minute of the head delivery. Okay, now. So what happens when there is a okay, now. So what happens if the head is came already, but the shoulder is not coming within 1 minute, then you have to do these maneuvers. The first one you are doing is the call for help. See here. See here. So okay. So the first one is the McRoberts maneuver. Okay. So you have to flex the legs of the mother against the see here is the abdomen, then abduct. It is more commonly injuries. So while doing this one, what is the most common injury? Literally leads to lateral and cutaneous nerve of thigh. First one you have to do the McRoberts maneuver. Okay. Then you have to do the what? Then you have to do the suprapubic pressure, also known as Rubin 1, or suprapubic pressure with leg maneuver is a Rubin 2. So you have to do the what? Suprapubic massage. Pressure. P for what? See, help. First one is the head. Hechra. It means, see, the mnemonic is here, the helper. Remember, something is happening to me. Hello. Okay. So, see, for the solar dystocia, guys, the mnemonic is the helper. H for what? H for call for help. Next one, E for what? A for legs. Okay, na? H for help. Okay, L for legs. It means you have to flex the leg. Means you have to perform the Mac Roberts maneuver. The next one, P for suprapubic massage. Okay, na? Suprapubic pressure. The next one is the E for the what? Woods cards. Woods. It means the enter the maneuver. Next, it means D. It means Woods cards. Corkscrew maneuver. It means to the correct maneuver in delivery. Shoulder dystocia progressive rotating the posterior shoulder 180 degrees. Array. It's okay, ra? Actually, I confused here, so I'll try to take another session. Okay, so I'm going to stop the session here. Okay, now, so we are done until the here 147. Okay, I will try to continue from 148 in the next lecture. Okay, thank you very much, guys.